All right. So is it okay to plate a not too loose periprosthetic hip fracture? A's and B2s, as was mentioned, type A really occurs around the proximal metaphysis, B2s around a loose component, but typically there's sufficient bone stock, and usually we require revision surgery. What we're going to talk about when not to do that. There's really no clear consensus on this. We look back at the Swedish registry, 1,000 fractures. Interesting thing, about 70 to 75% of these periprosthetic fractures occur in the presence of a loose component. Most recommend a femoral stem revision to avoid any further loosening or failure. But the real big question here is revising the stem always necessary if the femur component is not too loose? So let's try to answer that. This is an algorithm I think we're all used to. This is including the Vancouver Bees. What we're doing here, we're going to skip this and go to ORAF. So I think the thing is really the diagnosis is key. As it was mentioned by Nirmal, history. Is there any pain or dysfunction prior to the fracture? Standard x-rays for review, trying to compare them ideally to previous x-rays to see if there's any changes. I find CT is really valuable to see if there's any specific fracture lines not seen on the x-rays. Also looking for any evidence of loosening, radiolucent lines, or if there's been any changes to the cement mantle. Checking inflammatory markers, as we know, they may be up, they may be down, they might be elevated secondary to the fracture itself. I think if they're elevated and there's even if they're negative and there's suspicion of infection in correlation with the fracture, then the patient may need an aspiration. So what I like to go over is really the intraoperative stress test, and we'll go over how best to test it. And everyone probably has their own algorithm to that. Do you dislocate it? Do you pull on it? So how do you pull on it? Translate it, rotate it. These are things that I use in my algorithm if I'm considering whether revising the stem or if it's not too loose to do an RF. Obviously, we always have the obvious. We know it's too loose when the femoral stem looks like it's out. I'll show a case example demonstrating that. It looks like it's subsided without settling. It pulls out, it's an obvious one, translates out or rotates out. So in this algorithm that I use, patient's history is important. Say they had no specific pain prior to the injury. Standard x-rays don't show any frank loosening. CT doesn't show any loosening or any frank loosening. Inflammatory markers, it may be elevated, it may be normal. This really gets down to what I consider the intraoperative stress test. So how best to test it? I think every surgeon has their own preference. Dislocating it, certainly controversial. I think in some instances when I have a suspicion, I am going to possibly dislocate it primarily because I think that's the best way to really get a sense if the stem is loose. So how do you do that? Some surgeons like to pull it up by hand. I prefer either a bone hook, depending on the prosthesis, it actually has a removal device specific to that. Then I'll go ahead and connect that. But either way, I want to leverage some force. If it's not too loose, it's basically not going to really come out. If it's too loose, obviously it's going to come out pretty easily. Translating, I call it a translation test. If it's not too loose, it shouldn't really have a lot of gross translation within the femur, and then rotating it as well. So this is basically the algorithm I use to help determine if it's too loose or not too loose. So if it passes all these tests, and maybe one or two don't pass, but overall, if it passes a majority of them, then I think it's okay to do an ORIF without revising the femoral stem. So let's go over a couple examples of not too loose. So you can see this x-ray, really Vancouver type A, you see the greater and lesser troch fractures. Key things are the stem has not migrated, doesn't appear to have any settling. Another example here, the same case. Again, stem looks fairly stable. Patient's brought to the operating room. A lot of these I will have pretty much the whole kitchen sink, if you know what I mean, and just in case the stem is too loose and I need to revise it. So these go, as we all know, with a lot of instrumentation, revision stems, things of that sort, so we're not caught not being able to revise the stem if needed. So this patient is found not too loose, undergoes ORIF. So just as Dr. Ritchie was mentioning, we try to cross all over. This one goes from essentially across the metaphysis there. So just an example of not too loose. Another case, patient has a fall, determined not too loose or too loose. You see here, AP image doesn't demonstrate any migration of the stem. And in these circumstances, same thing, going in the operating room with a lot of tools in case we need to revise it. I make the decision to dislocate it, intuitively based on that whole algorithm I went through. If I don't have a high suspicion, I still will do a stress test on the stem, but I may not dislocate it. As you know, a dislocation, sometimes you're disrupting the capsule. It may lead to other issues and instability issues in the soft tissues. So if I can avoid dislocating it, I will. And this patient underwent open reductional fixation from the top. And then my final example here is too loose. All right, this is the obvious. So you can see the stem has basically migrated, it's subsided, it's gone below the fracture line. So this is a case that I won't necessarily go in trying to assess the stem. I will still stress it. I'll go through that algorithm, but essentially you can see this is the more obvious of when it's too loose, and I would recommend doing a revision. So this undergoes a open reductional fixation, a long revision stem, as well as a plate adjunct for open reduction and full fixation. And then I'll just touch on two things that I think are important in the care: bone graft in addition to plate, whether it's autograft or allograft. I think it's important to restore loss or poor bone stock in some of these patients. I will use routine cancellous autografting. Some will recommend morcellized or struck grafts. In addition, we can't forget the post-operative course, avoiding another fall, optimizing balance, working with a therapist, optimize their home and rehab settings. And as we know, optimizing their vitamin D intake. These patients will undergo laboratory analysis. As we know, it can help improve patient balance, increase their bone mineral density, and help reduce further risk of fall, because we all know we don't want to have to revise any of these after the fact.